cord again tonight. So life is good. All right, so pre-gestational problems. What does that mean, pre-gestational problems?
Issues before pregnancy.
Okay. All right, so we're going to look at diabetes, okay? And we're also going to cover gestational diabetes, which is diabetes after pregnancy. But we threw it in all at the same time because it can be kind of, it could be kind of confusing. So any glucose intolerance with onset or initial diagnosis during pregnancy is gestational diabetes. Okay, so they may come to the pregnancy already having diabetes. So we're going to just continue that treatment. However, if they never had diabetes and now all of a sudden they're pregnant and now they have diabetes, it's called gestational diabetes. Now, in early part of pregnancy, diabetes really isn't a problem. If they're going to develop gestational diabetes, or even if they're overt diabetes, usually isn't a problem because of the pregnancy. And so that's why we don't screen until over halfway through the pregnancy, okay? Because we're not going to get good answers as far as diabetes and its effect on pregnancy. It's the second half of pregnancy that starts to become a problem with insulin, okay? Now, for any woman at risk, for risk factors, if she comes in for her first prenatal visit at 12 weeks or 4 weeks or 8 weeks, if she hits the criteria for a person to be at risk for diabetes, whether it's gestational or overt, we're going to test her right then and there, okay? And what we do is we do the A1C, we do a fasting, and we do a 2-hour challenge test, okay? So if her A1C is greater than 6.5, if her fasting is greater than 126, and if her 2-hour is greater than, if her 2-hour challenge is greater than 200, we are going to diagnose her with overt diabetes, not gestational diabetes, okay? However, if she doesn't meet those criteria and we go through her pregnancy, in about 24 weeks, we're going to test all pregnant women for gestational diabetes. Risk, no risk, okay? All of them, okay? Now, there's two approaches. There's ACOG approach and the International Diabetes Pregnant Women approach, okay? So, which approach do you use? Do you use both approaches or do you just do one or the other? It's physician preference, whichever one they're most comfortable with, okay? But anyway, so if we're doing the ACOG approach, it's kind of a two-step approach. So we'll first give them a 50 gram glucola solution, and then we will test their blood sugar at 1 hour after they drink that, okay? This test, this first step to this ACOG test, it doesn't matter what time of day you do it. It doesn't matter if they fasted, if they did fast, it doesn't matter, okay? Same, we can do it, okay? We measure their glucose at 1 hour. If it's above 140, then we go to the 2-step. If it's not above 140, we do not go to the 2-step, and she's not diagnosed as gestational diabetic. But if we have to go over the 2-step, it's now a 3-hour, 100-gram glucose solution, okay? So she does have to be fasting, and we do have to do this first thing in the morning after she's fasted all night. She drinks the solution, and then we test her blood. We test her glucose at 1 hour, 2 hour, 3 hour. She can't eat anytime in that 3-hour span, okay? Now, when we do all 3 of those hours, and we get our values, 2 of them have to be abnormal. So the initial fasting glucose would have to be greater than 95, okay? Then 1 hour after she drank her solution, she would have to be greater than 180. At 2 hours, she'd have to be greater than 155, and at 3 hours, she would have to be greater than 140. If any 2 of the, if she is greater on any 2 of those, she's gestational diabetic. Everybody got that?
So any two of those four is
Mhm.
diabetic.
Yep. Gestational.
diabetic.
Yes.
So the two-step is to do one test, and if it is above 140, do a second test.
That's the two-step.
not-
Okay, so if she's not above 140 on the first step, she does not need the second. Okay. All right. Now, if you go with the International Diabetes and Pregnancy Association, it's just a one-step. It's just a one test. She either passes it or fails it. She gets a 75-gram glucose solution in the morning after fasting. And then she's tested at 1 hour and 2 hours. No eating within those hours. Okay. If she will be diagnosed with gestational diabetes if any one of these are met. Okay. So she doesn't need 2, she doesn't need 1, she doesn't need 3, she just needs one of these to be met. Okay. Her fasting 1 is greater than 92. Her glucose at 1 hour is greater than 180, and at 2 hours it's greater than 153. Okay, so whichever program you choose, that's the one you use, and life is good. Okay? All right, so our baby risk factors. So, diabetes, you guys, whether it's gestational or birth, diabetes has its risks to mom. We know what those are. But for baby, it could be really bad. So congenital anomalies, these are more so if we catch gestational diabetes and if we control overt diabetes, we are probably not going to see these severe congenital anomalies. But if we have a brittle diabetic or an uncontrolled diabetic, she is going to have a really messed up baby. Okay? It can affect her musculoskeletal system. It can affect her heart, the baby's heart, CNS disorders. There's a whole list under each one of those categories. These babies usually don't make it to live birth. Okay? The big deal is macrosomia. What is macrosomia? Big baby. Okay? So if big baby is a risk factor, how can IUGR be a risk factor? What is IUGR? Intrauterine growth restriction. So that kind of means, am I touching it? Good. So how can I have a risk for being big and a risk for being small at the same time? Okay? What happens in diabetes? What happens to a person with diabetes?
Excessive blood sugar.
Okay, what happens to their vascular? Okay, they have vascular problems. How does vascular problems relate to pregnancy? To what? The uterus. Okay, so if mom has vascular problems, then then the uterus and the placenta are compromised. Therefore, we don't have these big beefy babies. We have a poor sickly baby. Okay. So RDS, after delivery respiratory distress syndrome. Respiratory distress syndrome means surfactant. So respiratory distress surfactant. Whatever you want to do to remember that. That means there's a surfactant problem. Okay? And with diabetes, high levels of insulin inhibit the enzyme necessary to produce surfactant. So why would baby have high insulins? Mom is the one who has diabetes. Why is the baby having high insulin?
Because it's exposure to the high blood sugars.
Right. So the blood sugars cross the placenta. The insulin does not cross the placenta. Baby produces their own insulin in response to the blood sugar that they're receiving from mom. So baby's got high insulin levels, and so therefore it's going to interfere with surfactant. Okay? Polycythemia in the baby. What is polycythemia? Okay? And that is accomplished because of mom's hemoglobin, her oxygen binding capacity. Okay? If mom has an oxygen binding capacity, how does that affect baby? If mom has an oxygen binding capacity problem, how does that affect baby? Baby's not getting enough oxygen. What do people do when they don't get enough oxygen? They breathe faster. They increase their heart rate. They produce more blood cells so that they have more cells available to grab oxygen. That's how baby gets polycythemia. Okay? Hyperbilirubinemia, so the baby's liver, because of the high insulins, babies have a problem metabolizing bilirubin. Okay? And then they have to deal with the polycythemia issue. So they're breaking down more, they're producing more red blood cells because of they're not getting enough oxygen from mom. And then when they're born, they have to deal with all those extra blood cells they produced, which puts them at risk for hyperbilirubinemia. Okay? And hypocalcemia, actually kind of related to the hypobilirubin problem, but they don't really know why. Okay? All right. Okay, so gestational diabetes, so they may or may not require insulin. They could be diet controlled, depending on how severe their diabetes are. Or if they come to the pregnancy with diabetes, they may already be on insulin. They may even have an insulin pump, okay? Human insulin, least problems. We usually do an intermediate and a fast-acting insulin for pregnant women. Lisopro is kind of, they're trending to choice. And again, we can give these, in the morning with meals, at bedtime, or they could be on a continuous infusion pump. So here's your 4-dose regimen. We are finding a lot of success with glyburide, a PO, oral, anti-hyperglycemic, because most other oral medications cross the placenta and cause problems for baby, okay? So if we have a diabetic or gestational diabetic in labor, we're watching her blood sugar every hour, okay? We may end up needing to put her on an insulin pump infusion, IV pump infusion of insulin, and adjusting her blood sugars and her insulin drip throughout labor, okay? But then the big deal is once baby is born, we've got to deal with hypoglycemia in baby. So baby was hyperglycemic in utero, and now baby's born and is hypoglycemic. Why is that?
Not being supplied by the mother any longer.
They're not being supplied the sugar by mother. They're only being supplied by their own sugar or what they take in dietarily, like their formula or breast milk. And so these high levels of insulin that baby's producing overwhelms the sugar that they have and drops their blood sugar, okay? So postpartum insulin requirements decrease for mom for both the overt diabetic and gestational diabetic, okay? And then if this woman was gestational diabetic, she's going to be reassessed. Her diabetes status is going to be reassessed at 6 weeks. And if it's normal, then the recommendation is for her to be tested, even though she's not pregnant, for her to be tested for the development of overt diabetes every 3 years. Okay. All right, so anemia, a most common problem in pregnancy, maternal problem in pregnancy, inadequate iron intake. So we supplement every pregnant woman with prenatal vitamins and or also, well, not and or, prenatal vitamins, and they may also be have a separate iron supplementation as well. Okay, so iron deficiency anemia, here's your maternal problems. So you can understand this. Anybody who's anemic, easily tired, susceptible to infection, cannot tolerate a blood loss. Okay, anybody who's anemic is going to have these problems. Okay, but it's a big deal for pregnant women because they lose such a massive amount of blood during delivery anyway, and if they don't have the blood volume, then they're going to have an issue, okay? So for baby, of course, low birth weight, prematurity, possibly stillbirth or neonatal death, because they're just not getting the nutrients from mom because mom doesn't have the blood carrying capacity, okay? All right, so sickle cell anemia, recessive autosomal disease, what does that mean?
It means it's passed on genetically from recessive.
That's been inherited from both parents.
Right, both parents, okay? Sickle cell anemia, so the sickling of the red blood cells decreases the oxygen carrying capacity, so decreased oxygen to baby. We need to handle mom's sickle cell disorder so that she doesn't have a sickle cell crisis, which may happen anyway. So she will get, definitely, this person will get, definitely get folic acid supplements. Okay, so here's some associated risk factors for mom with sickle cell anemia. Treatment, if she has a crisis, would be rehydration, oxygen, antibiotics, but also monitoring the baby throughout the crisis, because if it's severe enough and affects baby bad enough, we might need to take baby. Okay, here's your baby risk factors: preterm labor, prematurity, intrauterine growth restriction, low birth weight. Those are, those are probably going to be those are going to be the risk factors for any baby whose mom has any type of anemia. Okay, because baby's just not getting the nutrients. Okay, folic acid deficiency. We will put all women, so prenatal vitamins usually have the folic acid in it. Sometimes we'll need to give them additional folic acid supplements. If they're definitely diagnosed with folic acid deficiency, we will treat them aggressively with folic acid supplements. Of course, diet is a big thing for anybody with an anemia folic acid problem. Second most common anemia in pregnancy. So hemorrhage is a problem. Okay, so these are with just about anybody who has an anemia. But the big hairy deal with folic acid anemia is for baby. Okay, so folic acid anemia is a big risk factor for a neurotube defect. Okay. So this is a big important one, not just because of all the implications of anemia in general. This one will cause severe anomaly for baby. All right. Alcohol and drugs. I just got a few slides on this one. I'm going to go through this one quickly. So fetal alcohol syndrome. Fetal appearance is very pronounced for a woman who has abused alcohol during pregnancy. And this is what these poor little babies look like, in addition to intellectual, mental disabilities. Okay. All right. I've put these slides on here, an easy way for you to just look at different types of substances mom could be abusing and how they would affect baby. Okay, so the big hairy deal is fetal growth restriction, IUGR, mental and cognitive delays, but the other big hairy deal is withdrawal symptoms. So a baby withdrawing from substance abuse is horrific. Okay, these babies can be admitted to the NICU and could be there for weeks to months, and they have to go on a withdrawal program. So methadone or morphine. It's horrible. Okay. Running through HIV and AIDS. So if a mom has HIV or AIDS, we really need to get her on antiviral treatment prophylactically to help cut down on the risk of transmission to baby. Okay? You know, baby can be exposed during pregnancy, but the greatest risk is during labor or any type of trauma or amniocentesis or things like that, okay? Baby can be exposed, all right? And also through breast milk. So we do everything we can to decrease the possibility of transmission to baby. So we want mom on the antiviral therapy. We can be testing mom's levels. If she has viral loads less than 1,000 copies per milliliter, then the risk is like down to less than 2%. Okay? So anyways, you know, sometimes depending on physician and mom, the decision will be made whether we will do an elective cesarean birth at 38 weeks or whether or not this woman can try a vaginal delivery and risk. But you know, we can test her her viral load, and it's possible she can have a vaginal delivery without transmitting to baby. Breastfeeding should sometimes be avoided, but if mom's on antiviral therapy and her copies are again less than 1,000 per milliliter, then the transmission is very low. So if it's really super wazoo important for mom to breastfeed, then we can try to make that happen. All right. So babies will be tested, okay, and if they are starting to test positive, then we'll put them on antiviral therapy in hopes to cut that transmission, okay, or cut that their levels of contracting. Okay, so we're going to run through heart disease. We're going to run through heart disease pretty quickly, but if mom has heart disease, whatever heart disease she has a pump problem, she has a volume output problem, cardiac output problem, she has a valve problem, okay? So what that's going to trickle down to the uterus is decreased blood flow to the uterus, okay? Therefore, what do I keep saying? Decreased nutrients and oxygen to the baby, okay? And then the other thing is, on mom's side, depending on her cardiac disorder and the management and her, how sick she is with her cardiac disorder, whether she can even tolerate a pregnancy. Because what happens when a woman gets pregnant to her blood volume? It increases. What happens to her cardiac output? It increases. And if you've got a heart that can't handle normal blood volume and cardiac output, you're putting more demands on her heart. So her ability to tolerate pregnancy is associated with how severe her heart disease is. Here's several different types of possible heart diseases that a woman can have that can affect her health and her pregnancy, okay? And again, these all may be managed very well, but then you add pregnancy to her heart disease and it could be a severe problem. Here are a few more different types of heart diseases we could see. If a woman has heart disease and she gets pregnant, she can see an OB physician, but she'll probably be referred to a perinatologist and maybe a perinatologist with a specialization in cardiac disorders, okay, just depending on what's available in your area. Okay, so I put this one up here, peripartum cardiomyopathy in pregnancy. Very rare problem. This is basically congestive heart failure, but in a pregnancy form, okay? And this happens to people who have no heart disease, no health issues, no asthma, no hypertension, no nothing, and then all of a sudden they're almost dead on your bed, okay? And the reason why I put this up here, and I'm very kind of passionate about this, is because my best friend, 18 years ago, got pregnant with her one and only child, had a horrific labor, 3-day labor, ended up in a stat cesarean section. After the C-section, her course was normal, everything was normal. She was discharged normally, baby was discharged, everything was great. Went home on her first day of discharge, went home, had visitors, everybody's celebrating, having a wonderful time. She puts the baby to bed at night. She goes to bed and wakes up at 2 a.m. almost dead. Couldn't breathe, diaphoretic, chest pain. Her husband, they lived 35 minutes from the nearest hospital. Her husband rushes her to the ER. Her oxygen saturations were 60, and she was in severe congestive heart failure and almost died. So, give me chills. Anyways, she recovered and is perfectly fine. She has no heart problems. She has no problems. She's healthier than me. But they advised her, don't ever get pregnant again. Because at any second, it could kill you dead because of this. Does everybody want to have children? If you have RN, after your name, if you have any initials after your name, go see a perinatologist. No, I'm teasing. I'm just teasing. You're not, Dustin.
Risk
Oh, What?
Is this unknown risk factors?
Yes,
or any-
there's no risk factors. There are no risk factors. This can happen to a perfectly healthy individual.
What percentage of pregnancies?
Oh my God, like 0.0000 of 10 million. I don't know.
Okay.
It's super super rare.
Nothing you can do about it. So.
I know.
Okay, so management of our heart disease woman is going to be what her management is for her cardiac, except we're going to step it up a notch and do it more often. We're going to keep an eye on her heart function and her health during this pregnancy. Okay, so you know, we may need to put her on antibiotics depending on her heart condition and whether or not she's going to have a surgical birth. She may need to be on heparin during labor. She may need to be on diuretics, just depending on what her cardiac problem is and how it's affecting her health and the pregnancy. And this should be managed by the perinatologist. Okay. All right. So they grade heart disorders. You probably know this or will know this in your Med-Surg 666 people, but they grade heart disease class 1, class 2, class 3, class 4. Class 1 is, you know, asymptomatic, no physical, no problems, no health problems, no activity problems. This person can function normally. Class 2, slight limitation, so they're not running marathons. Class 3 and class 4, they start having more complications. Now this is just a heart patient, not pregnant. Okay, this is how they grade those. Okay, so once we've graded her heart disease, then we kind of determine what her risk factors during pregnancy are. And you can imagine class 1 and class 2, she could probably get through that pregnancy without any problems. But we're still going to keep tabs on her. Class 3 and class 4, she's going to probably have some problems and some complications that we're going to need to manage. So we're going to watch them even more closely. Okay. So of course we're going to meet the physiological needs of the patient as well as the pregnant woman. As the baby. As the baby. Okay. So we're going to have diet guidelines, activity guidelines, with strict rest periods, strict activity limitations even. Okay. Of course, avoid infectious sources, and then frequent cardiac assessments during pregnancy. Now, even in the okay, so this is interpartum. So of course, so this is when she's in labor. Interpartum, right? This is when she's in labor. Okay. So We're going to watch her vital signs frequently, and continuous electronic monitoring. Listen to her lungs. We encourage a head up or a side lying position to less stress on the heart. Oxygen, diuretics may need to be needed, but sedatives and analgesics, like hit this woman hard with all your guns, okay? Because labor is a stressful event, and we want this woman as pain-free and relaxed as possible. So then comes the problem of pushing. So how much pressure does that cause in a normal body and to a normal heart when we're pushing, okay? And then compound that with heart disease. So we really need to help these people along. There may even be a lot of instrumented vag deliveries. What does instrumented vag deliveries mean? Forceps or vacuum, just to decrease her pushing efforts, okay? All right. Okay, so now in the postpartum period, we're not okay. We've delivered the baby, but we're still not okay. Mom still has that huge blood volume that she needs to deal with. So we're still on top of this woman postpartum until all her values have come down to normal pre-pregnant values. Okay. All right. Again, side lying. Is this a duplicate accidentally? Oh no, this is postpartum. I'm sorry. So we're still maintaining the head up, side lying positions, and stool softeners. Big thing. So yeah, we want to help them push the baby out. We also want to help them push anything else out. So we don't want them straining. Okay. Breastfeeding is fine for moms and babes. Okay, usually 99% of the time. So go ahead and let her breastfeed. Pre-gestational medical conditions. Well, okay. So your mother may have other problems, not just heart disease. She may have any one of these problems. Okay, asthma, epilepsy, blah 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 blah. Okay. Asthma, as you probably are aware, so if she has breathing difficulties, guess what happens? Breathing difficulties, mom's having breathing difficulties, so oxygen, so placenta, so baby, yeah, it's a problem, okay? So with asthma or severe asthma, uncontrolled asthma, these could be the problems for baby. Now, so a woman has asthma and she gets pregnant. That doesn't mean like, her baby's going to be IUGR or low birth weight, okay? It's the severity of her disorder, okay? And how the pregnancy impacts the disorder, okay? If it doesn't impact it and she does just fine, we're all good, okay? Epilepsy, mom has a seizure disorder. She needs to stay on her seizure medicine. What?
If mom's starting to get hypoxic, is she going to tend to cut off blood flow to baby to save
Yeah.
mom?
The uterus is a non-viable organ. That thing can live or die for all the body cares. Okay? The uterus gets it last, or gets it not at all. Okay? It's a non-viable organ, according to the body. Okay? Okay, epilepsy. So there's a lot of risk with the epileptic medications causing congenital problems, but do we want women seizing while they're pregnant? No. So they need to stay on their epileptic medicine and take the safest medication for the pregnancy, okay? Folic acid, of course. So here's your risk for those epileptic medications. But you just try the safest. So you try the safest medication for pregnancy at the lowest dose to keep the woman from seizing. Okay, so that's your benchmark. Okay, controlling seizures. So you try the lowest dose, you try the safest medication for pregnancy, but you start tiering up to control the seizures. Okay, hepatitis B. With the hepatitis B, so we were going to want to treat this baby at birth, okay, with immune globulin, Hep B immune globulin, okay. We routinely vaccinate babies. Hepatitis B vaccination on all babies routinely, period, unless mom says, no, I want to wait till I get to the pediatrician. But if mom has hepatitis B, then we will use the immune globulin. Okay.
So, question on that. Babies aren't, like, their immune systems aren't able to produce antibody anyway for the first 6 months, so why do we give them shots?
Well, it's like a passive acquired, okay? So we put that in there.
Okay, so that's what we're doing.
Yeah.
We're not stimulating a response.
No.
Okay.
Okay? Anyways, okay, so I'm sorry, guys. I'm going to end up recording tonight anyway, so I might as well just give up the ghost. Okay, so just like HIV, transmission usually occurs somewhere around the time of birth, okay, or labor, okay? So, you know, mom might have an increased incidence of preeclampsia or postpartum hemorrhage, but we watch for that on all of our patients, so bring it. Bring it on, honey, we'll take care of you. Oh, we're on thyroid. I'm sorry. Read the slide. Okay, hyperthyroid. Thyroid. So the big thing with mom related to her pregnancy is the stress of the pregnancy may stimulate a thyroid crisis, okay, that we would have to treat, all right? Otherwise, she continues her medication, and the one thing that we monitor baby, so monitor baby's growth. So if mom's on medication, so that medication crosses the placenta and then could cause a problem for a toxic problem for baby, because baby produces their own thyroid hormones, so we're getting extra doses. All right, so okay, so we're going to do non-stress tests. We're going to monitor baby's growth, baby's wellness, make sure baby's doing well. Hypothyroid, okay, same thing. So we want mom to still take her medication, and then if mom stops her medication because of pregnancy, then she's probably going to lose the pregnancy. High risk of spontaneous abortions with that. Multiple sclerosis, so we just continue to manage mom's symptoms, and whatever stage mom is in multiple with her MS, then we may need to do a lot of assistance during labor. Okay. Low birth weights for baby, rheumatoid arthritis, so kind of similar to MS. During labor, this woman may have a few more problems, so we might have to manage her more aggressively during labor. Okay. If she's on prednisone. So people with MS don't live on prednisone, but when they have not an MS, rheumatoid arthritis, I'm sorry. So they have like periods where they take it, like I'm not sure what the regimen is, like they'll take it for a month and then they'll be off for 3 months or whatever. So if it happens to correspond with their pregnancy, baby could be affected slightly, but okay, so here's on lupus. So we need to manage mom's lupus irregardless of the pregnancy, because we don't want to have flare-ups, but that puts baby at risk for fetal growth problems. Mom's at risk for preeclampsia. Everybody's at risk for preeclampsia, actually. So hopefully, we don't have problems with her. She doesn't have problems with her lupus during pregnancy. So here's more risk factors for baby, pretty similar to just about any type of disorder: intrauterine growth restriction, prematurity, babies can develop or display neonatal lupus after delivery, and they display it, so they don't really have the lupus, but they could display lupus symptoms for a period of time, and then they go away. Congenital heart block might be a big issue for babies. These are diagnosed in utero, and babies managed in the NICU afterwards. TB, so you know, most women with risk factors are screened for TB. We do put them on treatment, and then do a frequent skin TB tests afterwards, and then just manage her pregnancy as well as we can until baby's delivered. And then here's our problems for our baby. So if mom is inactive or has had treatment, then she can breastfeed. But if she has had active TB or has not had treatment, then we discourage her breastfeeding. Okay. Okay. I wonder if that was, what chapter was that? Yeah, I'm going to have to record. I got a whole nother chapter. Oh shoot, I'm on this one. Let me see here. Yeah, I'm not even going to start the other one. I have 3-4 minutes. So, sure. It is,
Oh, did you know that chapter 14 is actually chapter 21?
yeah, did I not fix that? I thought I fixed that. I'm going to fix it after you. I didn't fix it. Maybe I didn't do the study ones. I did the lecture ones. I did the study ones?
I downloaded the lecture one this morning.
Okay.
I thought I downloaded the lecture last night. When
Well,
did you fix it?
I'll just replace the study ones. Actually, the study ones are, yeah, I will do that. The study, I wonder if the study ones are, wait a minute, let me stop my recording so people don't hear me babble.